and the lot of foramina which when you go in the base of skull, you can encounter those foramina and the structure along with that. Whenever you are doing any sort of surgery, either on a skull base or on a face or on any part of the body, we'll have to divide into 3/3 as we divide the face into 3/3. So I always divide this procedure also into a 3/3. One is the patient factor. That is also very important, whether your patient is compliant or not, whether he is, motivated for that surgery or not. That is most important. And all other morbidities and comorbidities which he is having before surgery, you must look into account before you go for this surgery. Then the surgeon factor is also very important. The first and foremost is whether the surgeon is skillful for this procedure or not. That is the most important question to ask for. That the other thing is whether the surgeon is ethical, because ethics are more important. Many times you attempt a procedure which you don't know, but you attempt for the sake of money. That is unethical sort of an approach to any sort of surgery, whatever it is. So that should be avoided. That is most important thing to look into. And the third most important factor is the family factor. More of the families, I am practicing maxillofacial surgery, and in particular oncological surgery, I doing tumor surgery, nothing else, in which I have seen many parents and many family members, whosoever, even sons and daughters, they come to me and say that we don't want to have any sort of a surgery, so counsel my father and leave it alone. So this is very important. If you push them for that surgery, and in the way when you are going, because it's a long journey as far as tumor surgery is concerned, it's not only surgery, then radiotherapy, then chemotherapy, and then all feeding processes which will be going on. Patient is going to deteriorate day by day, and family, if they don't support, then you will be nowhere. All the responsibility will be on your shoulder. So family's shoulder must be used at that moment. Counsel them again and again, and then you start this sort of a procedure. If any procedure you are doing, this is most important thing. Again, the other challenges, basically, as I have already discussed, you'll have to maximize the resection. You have to remove the tumor in toto. You are not supposed to leave anything behind. This is also a biggest challenge as far as skull-based surgery is concerned. Then by doing the maximum resection and maximizing the resection, minimizing damage is also very important. You will have to take into consideration this part as well. Then any neurological deficit, that is very, very important. Sometimes we are cutting down the mental nerve easily, and just telling the patient that nothing will happen, even a numb lip, you can imagine what is going to happen. That's a very, very important thing to know. So the other challenges, skull-based tumors are critically and deeply located. That is again a big challenge. Then it is the access. This is, literature says the access is also very limited, and that poses a lot of problem as far as skull-based surgery is concerned. Sometime, as I have already talked about in a preamble, that sometime you will have to leave some tissue behind if it is very near to the major structure. And it can also invade the skull base, and at that moment the surgery could create a problem at that moment. Now, my first case, you see, it was a histopathological proven ossifying fibroma, somamatide ossifying fibroma. That is, you call it a juvenile fibroma. By looking at the histopathology as well, it's a benign tumor, but the tumor which is killing a patient could not be a benign. That is also a malignant sort of a thing. So you just imagine where the eyes are located. If you see the scan, the tumor is going into the brain and resorbing total sala turcica, pushing the pituitary gland up. And you see, this is the scenario at that moment, the both eyes are pushed apart. So that was the challenge, how to cater this issue immediately. So again, this is a frontal profile, and This is bird's eye view. Previously, this patient was operated upon by a neurosurgeon, removing some tissue and leaving everything behind, and this was the recurrence of the same patient. We took this challenge, and then we decided to remove the tumor toto. We divided the surgery into two parts, one in the intracranial at the same time, and then close it, and then extracranial, whichever it was located in the eyes and the nose and the maxilla. So two parts we have done. How we have done, just wanted to show you. Again, you just see the other images. The images are very, very important. If you see the image on that side, the corpus callosum is very close, and the pituitary gland is pushed very hard at that moment. And the pituitary gland, when you just push up and remove the tumor, you know, it will not function for another 2 weeks. When it will not function, the whole endocrine glands will be totally silent, which are maintaining all the dynamics of the body at that moment. So you'll have to have a support like T3, T4 will not be there, cortisol will not be there, adrenaline, and everything will not be there. So you'll have to take into consideration this pathway as well. You'll have to give a support. Then we'll have to see the vascular area, because it was near to the cavernous sinus and carotid artery. If you just cut it down, you will be nowhere then. So we'll have to see angiogram of the brain as well, whether internal carotid artery or cavernous sinus are punctured or not. When we were sure that it is away from these two structures, then we have entered into the brain. So again, you see, this was the same view. The craniotomy was done, and neurosurgeon was called for this. He did a craniotomy and pushed back the brain. We have taken the tumor out from the brain first. As I have told you that we have done in 2 stages. Intracranial part we have taken out. This is, you can see the tumor is coming up, and at the near the frontal bone from a frontal sinus, and then you can see this is the tumor which we have taken out from the brain, pushing the pituitary glands up. This is the defect into the brain which you are just seeing around. And then, you know, this is, I have pushed that pituitary gland behind, because at that moment the neurosurgeon told me that I can't do further push because brain will be damaged totally. So if we leave the tumor behind, the same thing will happen which he has having previously. The tumor will recur and then kill this boy. So I took the responsibility. I have pushed the brain up and then taken the tumor out from this. And then this is the closure of the brain part. Again, now what we have done is we have done a LIFO2 osteotomy and down fracturing the maxilla, and entered into the base of the skull here. And you can see in this picture, the tumor is coming up and the defect on the other picture. And this is the total defect. And we have taken total tumor from the base of skull, and from the brain we have already taken out, and then put everything back. And this is the suturing. And this is the immediate post-op picture of this boy. Eyes goes back because everything is taken out. So, dear students, the things have not over as yet. If I could run this video, ये चला सकते हैं आप वीडियो जो है? ठीक हो? You just imagine immediate post-op. He is saying, I am well oriented with the space and nothing was wrong. But after that, the story is still not finished. He could be cerebrated a few moments later. So he is taking his arms up and down. So we successfully removed, and no neurological deficit at that moment. But later on, in intensive care unit, what happened is that I just wanted to show you. If I could run this video, please run it. So he is decerebrated, because at this moment the brain infection was there and he was decerebrated. But later on, this is the picture when I have discharged this patient and gone home. We have put this patient 1 month on ventilator, and very crucial and critical management we have done. Neurosurgeon and anesthetist and intensivist told us that finish it, he is dead. But we have not lost hope. And we tried, and this is the picture at home, you know, and he was eating something, and then later on, we discharged from the hospital properly. And later on, this is the picture from home we have got. Just right now, he is posing his mouth that every nerves and everything is fine. He is perfectly fine, moving around slowly. He will be, after that, as he's developed his muscles, he will be perfectly fine. So that was the challenge we accepted. So next patient we have received from Afghanistan. It was a plexiform neurofibroma. It's a malignant thing. So you just see and gone into a base of skull. You can see in the scan, the carotid artery was at hit, but we have saved that carotid artery, operated it. This is an extended Weber-Ferguson incision through which we have approached the base of the skull and taken the tumor out. This is tumor just coming up, and this is the defect which we created. And now we are just showing the foramina, the mandibular foramina base of skull that we have saved totally, and then closure was done. This is the tumor from maxillary area, and this is from the base of the skull which we have taken out. So this is a post-operative picture, intraoral closure, extraoral closure, and on a discharge. Ladies and gentlemen, after discharge in 2 weeks, tumor came back. This is a very notorious tumor to recur. It came back and the patient came to us for the removal of that. You can see the swelling on the frontal bone, and that was a tumor. Again, we went in and we have taken this tumor. This is the tumor exposure. Hemicoronal incision was given and removed it. You can see the brain. You can see the brain through the last picture, and we have completely removed. This was the tumor which we have removed, and this is the closure basically. And then we have sent the patient to the radiotherapy. It's doing very well at this moment. This was a frontal bone trauma 6 months back and ignored. He developed a mucocele. It's a very minute sort of a thing as far as mucocele, but what it creates, you can see in the eye has been pushed down and pushed aside. So if you just see the scan, so that was the pushing the brain back, and it was the total area was occupied by mucocele. This lining which was left in the frontal sinus, the collection of mucus there, and that was a mucocele. So we took this challenge, and we just incised through the previous scar, and we gone in that we have taken the bone out. This is this mucocele which we are taking. We have done our own. We have not involved any neurosurgeon into that, and that you can see the brain underneath, and we have removed this mucocele, and then reconstruction was done and closure was done, and this is the post-closure picture of the same. Another challenge that is also very benign looking lesion, that was lymphangioma, gone into a base of a skull, involving the total end organ of the facial nerve, lip and the eye, you can imagine. He is a very young boy, but that was a great challenge how to take it out, because everything is involved around and saving his face as well. So that was the biggest challenge. So what we have done is we resected around. This is the facial nerve which we have spared it, total periodectomy, all the resection done, and in the conjunctiva we have removed the tumor. This is the conjunctiva. You can see a smaller eyeball pushed behind into the photograph, and we have just taken everything out from here as well. This is the tumor which we have resected and closure. The deltopectoral flap was insetting, and still we are planning to resect it and then repose it. The eye, which is much improved now, and it is still under the treatment, but successfully discharged. This case was seminoma, operated upon germinal cell tumor, operated upon 5 times before by a general surgeon, came to me. What was the challenge here? Because when we having a color Doppler, duplex color Doppler, they said that the major vessel going in, carotid artery, internal carotid artery, jugular vein, everything is fine, nothing wrong. So what I did is, when I operated upon, so what I saw that the internal carotid artery was invaded by the tumor as well. So there we were stuck. At that moment, we have immediately cut the one stump of the external carotid artery and interposed to the internal carotid artery. And the blood supply from the external carotid artery to the internal carotid artery, and save this patient there and then. So this is post-operative, 1 month post-operative picture. He was perfectly fine, nothing wrong, nothing was there. Unfortunately, this boy I received from Aga Khan, the Aga Khan hospital referred this case to me, was blind by both eyes, ptosis on the both eyes, and you just see, this is the wrong placement of slide because we have changed and things have been changed. So if you can see this into the scan, it is pushing the sella turcica and the optic chiasma as well. The tumor was loading onto the optic chiasma and pressuring it, then that's what, and into the orbit, ptosis and blindness was there. So what happened is, when we have just operated upon Leaford 1 osteotomy, gone into base of skull, this is the tumor which is coming up, and it is, you see, this is the scan and this is the boy. Look at ptosis gone immediately. Eye VN was back, one eye total back, one eye was 70% back, and later on total VN is back. So boy is saved. This is after 10 days, still pack is into the nose. So total VN was back and there was no ptosis. That challenge we have also accepted. This patient was also मुझे पता आपने बदला लेना है. So anyway, I'll be quick. So this was also received from the Aga Khan hospital. So Aga Khan people referred, we have done an angiogram and we have seen the vascularity of the tumor, and we have removed, we have pushed the maxilla aside, put the nose up, and we have gone into, and the tumor is coming back out. And this is the post-operative picture. No ptosis, no loss, no neurological deficit in this case as well. That was a myeloblastoma. I must be very quick. Previously operated upon, defect, and we waited for the reconstruction, and then we have done reconstruction, free fibula and with skin paddle, and then implant. This is the post-operative picture of the same girl. And this picture, I am just going to show you, not much pictures are with me. This is I have operated upon in Bangladesh, gone in a base of skull. Why I have put this picture here, I just want to give you a message over here. This was the team with me in the Bangladesh at that moment. They have told me that blood is arranged and everything is fine when I operated upon. I told them that 2 liter blood is in a tumor. When I dissected, immediately it will be going into a hypovolemic shock. But they misled me, and she gone into a hypovolemic shock. She was almost at the end of her life. I have a B negative blood, and one of the scrub nurse is B negative blood. We just lie down and we given a type blood, not a cross-matched blood, and we saved this girl. And you can see this back. Yes, she is a girl, tracheostomy closed and post-operative. They have sent me the photograph. So I think the last case, which I'm just going to show you, just see a young boy fell from a tree and the peg gone from one side to the other side of face, almost dead received. If you see this case, the scan, the peg going from one side to the other side under the base of the skull. Here the danger was the both cranial internal carotid arteries and jugular veins must be gone by this. But what I did is, I have operated upon, I took the responsibility, did immediately tracheostomy and exposed one side of the greater vessels, the other side of the greater vessels, checked them up. One internal carotid was damaged, repaired there, and one internal jugular was damaged, I repaired there and then I have taken this peg out. I just pulled this peg out, and this was the hole at that moment through which I have just taken peg out, and even not a single drop of blood come out, because we have repaired the vessels previously. We haven't taken risk. And this is the picture, post-operative picture, some few days, and this is the boy after discharge. So this is how we have taken the challenge and saved this boy's tracheostomy closed, and boy is back. Thank you so very much. And the last slide, I have this, I like so very much, poetry of Iqbal. I have put that जवानों को सोज़े जिगर बख्श दे, मेरा शौक मेरी नज़र बख्श दे, खिर्द को गुलामी से आज़ाद कर, पीरों को, जवानों को पीरों का उस्ताद कर. आपको हमारा उस्ताद होना चाहिए, हमें आपका उस्ताद नहीं होना चाहिए. ये सिचुएशन क्रिएट हो. थैंक यू सो वेरी मच. Thank you, Shaji, for extra time.
It's a magical work. And Dr. Riaz Wadaij.
Thank you very much, sir, for your befitting words. To deliver today's next lecture,
Dr. Riaz Wadaij is always doing a magical work, and Allah Ta'ala ने इनके हाथ में शफा भी दिया है. It's not everybody's work, it's not every dentist can do it. So we appreciate that at least he is among with us. So time is time, no badala.
to deliver today's next lecture on surgical endodontics, I would like to invite Dr. Fahad Umar, Assistant Professor in Department of Endodontics, Aga Khan University, Karachi.
Thank you so much. Just my luck. I have to now follow up Dr. Riaz's talk.
सर कौन सी ये वाली? सर ये देखिए.
ये
वाली?
नहीं नहीं इसको
इसी पे चलाता है, डायरेक्ट यूएसबी से चलाता है.
स्लो चलेगी?
नहीं चलेगी.
So Dr. Riaz showed big surgeries. I'm going to be showing small surgeries. And I made a career out of doing small surgeries. So this was 2011 when I graduated from the operative dentistry residency program. Thank you. And I initially joined the operative dentistry residency program. Are you able to hear me properly? No? Okay. Okay. So meanwhile they set it up, I'm just going to do a pre-talk. So when I graduated the program, and before I entered the program, I always wanted to be an endodontist. And so I got a lot of learnings from the operative dentistry residency at AKUH. But at the time that I was a resident, microscopes weren't really mainstream at the hospital. And after I graduated, I still felt that there was some yearning, something was left. I wanted to improve a little bit more. I couldn't really do anything for 3-4 years or 5 years, just doing clinical dentistry at Aga Khan University Hospital. And then, but I always kept looking for resources or opportunities where I could go and study some more and maybe work on my endodontic skills. And I ran across UPenn. They offer international residency. And this was in line with my future career goals. I could go and study there and as well as come back, do my work, go back, come back. So it was a 2-year program that I went through. And there were a couple of learnings from them. And when I was doing the program, during the program, I would come here and do my lectures and also talk about how, you know, I've been doing microsurgery. And in my lectures, I would usually show the cases that I've been doing. And in this lecture also, there are cases that I'll be showing that I do. But I also wanted to now impart some of my experiences and my learnings from these 4 or 5 years that I've been doing surgery. So this lecture is sort of like a cumulative of 4 or 5 years of doing surgeries and the challenges that I faced doing these kind of surgeries in our part of the world. So this is a U-pen. When we entered the dental building, this is the Robert Shatner Center at U-pen, and this is very famous because a lot of endodontists famous as well, like Gutman, as well as a lot of famous guys come from this university. They also know about our part of the world because Dr. Iqbal Mia was a program director there, and he was from Pakistan. Here you see Dr. Singyuk Kim. Is the pointer working? Can you see that? Yeah, Singyuk Kim is known as the pioneer of microsurgical endodontics, and he was the first one to incorporate microscopes in surgical endodontics. This is Dr. Kratchman, and they are famous for the Kim and Kratchman classification for microsurgical endodontics. And during my journey, I met with a lot of colleagues as well as friends and peers who've taught me a lot. Dr. Mito Kohli was my program director, and Dr. Martin Trope, he's famous from International Association of Dental Traumatology. They've all took out time and gave me time, and I've learned from them. And finally, when I graduated, I had to give an exam. Dr. Frank Sadzer actually came to our Khan University Hospital. I had to do a couple of cases in front of him, non-surgical root canals as well as surgical root canals before I graduated the program. And indeed, this was very fulfilling for me to go through this. And although the topic is about microsurgical endodontics, the basis of our skill set develops on using microscopes, and a lot of my skill set before the surgical endodontics was actually developed doing non-surgical endodontics. And we can do a lot of neat stuff, retrieve files and negotiate ledges when we're using microscope and using magnifications. With that being said, just going to talk about a couple of my surgical cases, and we'll just take them forward from simple cases to a little bit more complex cases. We'll try to cover some of the indications that are there in the book. So number one case is a 15-year-old girl who had presented to our clinic, and she had multiple bouts of swelling from a previously root canal treated tooth, and this tooth was root canal treated twice, and she still had a swelling. And when we look at the tooth, we saw that there's a well circumscribed radiolucency associated with the tooth. The tooth is already crowned. The root canal treatment seems to be of adequate quality. Maybe there's a small bit of inadequate fill at the bottom. And so we had a conversation with the family, and we did talk about having to do a retreatment again the third time, or another option would have been to do surgical treatment. The family thought that it'd be best if we go for surgical treatment this time around. And then before we do surgery, we always want to do a cone beam CT. I always like to plan my case beforehand, and here we can see that the lesion was approximately 14, maybe 15 millimeters in diameter. There was a labial perforation also involved with this tooth. And when we open it up, there was an osseous defect already present, We did our root resection, ultrasonic preparation, and retrograde fill. And this is our immediate post-op. Here I've used BC putty. In one of my initial cases, I was using bioceramic putty, and we'll talk a little bit more about different retrograde filling materials as I go along in the conversation that we have. Another thing that I always like to do is whenever I take something out, any lesion out, I like to send it for histology. Most of the time these are radicular cysts, and usually I tell my patients that these are going to be turning out normal, but it's always a good idea to send it for biopsy. And again here we can see that there is root canal treatment was, the biopsy shows that there's a root end, and there's a root canal filling material in the root. There are certain inflammatory cells, and this is indicative of radicular cyst there. So another case, and usually most of my cases that turn up is upper sixes, which are usually well treated, and they still have disease. Most of the time they have an MB2. And whenever I see these kind of cases, I always again like to go back and do a CBCT. I want to see where the MB2 is. So in this case particularly, the MB2 was quite far down deep. There was an MB2, but it was quite far down deep, and we discussed the idea of going ahead and trying to do a retreatment in this kind of case. But after our discussion, we did realize that it would be difficult to go down this deep because the MB2 was a little bit like more than 4 or 5 millimeter below the initial entry point of the MB1. And I told the patient maybe it will be very, very difficult to get all the way down there with ultrasonics. And perhaps another alternative would be just to go ahead and do a surgical treatment here. And that's what we decided to do. And we opened it up. And there was a lesion on the distal root also. So we treated that with the surgical approach. And lo and behold, there's a second canal. And also, if you can see in the first picture here, there is a crack. And this crack can only be seen, or could have only been seen had we used magnification in this case. And that's the reason that we use magnification in all our surgical cases. So we were fortunate to note this crack, and the resection was further carried down deeper. And then we did a retrofill, and we had a reasonably good outcome on this one. So case number 3 is again another indication of untreated area or an untreated root. Here the mesial root is not completely treated. One of my colleagues had tried to do a root canal but was not able to go all the way down in the mesiobuccal root, and the patient was symptomatic, and therefore the patient was referred to me for a surgical treatment. Now another complication that we noted in this case was that the mesial root was actually inside the maxillary sinus. So mesial root was dipping into the maxillary sinus. We usually don't really worry about our roots dipping into the maxillary sinus because we have some neat ways in which we can deal with the maxillary sinus perforations. So whenever there is a maxillary, the root is inside the sinus, I like to open up a little bit more apically. I like to expose the sinus, stain the Schneiderian membrane, and we try to put something in there. Now here you can see, here we have some sterile gauze that we already have made, and we tie some floss along with it and push that inside the sinus. As long as we are not pushing anything solid inside the sinus and it's just water and fluid, we don't worry too much about perforating the Schneiderian membrane. And most of the time we just tell the patients after the surgery you might have some bleeding from the nose or some debris, some water that's clears out in a day or two. So usually don't get very many complications if the sinus is involved, so long as we are careful not to resect the root tip or put something or push something solid inside the sinus. So this is immediate post-op. and this is our case number 4. So a primary treatment was done by one of our residents, and the root canal was of reasonably good quality. Maybe there's a little bit of an overfill at the apex here, but the patient was still symptomatic, had a gum boil. We waited 2 weeks. 3rd week, it wasn't getting better, so we decided to do a CBCT, and here we saw that there was a little bit of an overfill over here. And therefore, we thought it would be a good idea to go ahead and do a root resection. So again, opened it up, and here we noted that there was already an apical fenestration associated with this tooth. And the GP point was coming out of the root tip, and therefore causing persistent infection and pain to this patient. So we went ahead and did the resection. There was an overfill, which we had a really nice resection, and then we were able to prepare the root end. We also noted that there was an MB2 in the mesiobuccal canal, and we were able to prepare it and then fill it very nicely. We had a good outcome in this case. Another indication is aberrant anatomy or aberrant apical anatomy. So another case that we did was a patient presented with a long-term infection associated with a previously filled tooth. The patient had thought that he had gotten a root canal done elsewhere, but there was persistent gum boil associated with this tooth. When we looked at it, we noted that the apex was open, and also there was some aberration at the bottom here somewhere. And we thought if we do a root fill, most of the GP or MTA might get extruded, and we wanted to do a surgical approach here too. And we did a primary root canal, and then later we went ahead and did our surgical phase. Here I have used, instead of bioceramic putty, IRM. And I'm just going to talk a little bit more about my choices of retro filling materials and how they've changed or evolved over a period of time since I've been doing these surgeries. This is the completed case. So before I move forward, after 2, 3, or 4 years of doing surgeries, I wanted to find out how we were doing in our center, what our outcomes were like, and what are the long-term success or prognostic outcomes of our cases when we compare our surgeries to what's being done internationally. So we did a retrospective chart analysis, and the focus of this analysis was twofold. Number one, we wanted to find out how this kind of surgical procedure is going to affect in a low and middle income country. The other was that we wanted to use a 3D criteria of evaluation. Remember that the positive outcomes of endodontic surgery, which is reported in literature, and especially the microsurgical outcomes, are based on 2D outcomes. There is paucity of literature on 3D outcomes, and therefore we decided that patients who've gotten 3D CTs before treatment and who have come back for follow-up for at least after 6 months and are willing to get a 3D CT to evaluate their outcomes, we will be part of this study. And we ended up with around 27 patients in this study, and what we noted was that out of these 27 patients, if we looked at it 2D criteria, we got a success rate of around 88.5%, which was close to 90-something%, which is an international benchmark. And we thought, okay, we are doing good for ourselves, especially if most of our cases were molars and premolars. But when we assessed ourselves on a 3D criteria, our prognosis actually went down. It went down to 81%. And this is because the 3D criteria is a much more strict criteria, and 2 of our cases, which we had thought were successful on 2D radiograph, were actually unsuccessful in 3D. And therefore, there is a need to develop more understanding of the success and outcome of microsurgical endodontics when we look at it or assess it in a 3D, in 3D. Other interesting things that we do other than doing apicoectomies are intentional reimplantations. Intentional reimplantations are the types of cases that I do when I feel that there's some anatomical challenge in which I might not be able to do good apico, or there will be some other issues or complications for an apico. So, for example, this case was a right lower 7. There was a separated file in the mesiolingual canal. We tried to retrieve this file through conventional method. We were not able to do that. Patient was still symptomatic, and we discussed the possibility to do intentional implantation. We did our neat job, I think, and we have a good outcome in this case. This is a 1-year follow-up, and a CBCT was also done. There was no resorption or anything of that sort. Another similar case done recently, nicely done root canal, but still was symptomatic. Patient was referred by one of the GPs, and we thought it would be very difficult to go as far back and so far up in the right upper 7. So we decided to do an intentional reimplantation in this case. We had a reasonably good outcome in this one also. Another treatment modality that we're working on in our center is decompression surgeries. And usually we see that when there are big radicular lesions, patients are being referred to oral surgeons. And when they go to the oral surgeon, for example, this index case, this means big flap opening, removing all this epithelial lining, and probably compromising the vitality of all the teeth that are in the vicinity of the lesion. So we started doing decompression surgery in which we bespoke a NG tube into the lesion itself. And then we do a conventional root canal treatment. And when we do that, we then keep the patient on follow. Usually keep the tube in there for 3 months, and then remove the tube, and we just monitor the progress of the lesion. And we've had reasonably good success. As you can see in this case, the lesion has regressed almost 80%. It's not completely regressed on 3D. But on 2D radiograph, you can see that it's almost complete healing. We have noticed similar success in other cases also. We've written 2 or 3 papers. One has been published in Australian Endodontic Journal, and others are also on their way on this technique. And maybe we'll talk some more about it in other upcoming presentations, but something that we should be aware of. During my learnings, I wanted to inculcate whatever I had learned from Penn, because not everybody can go to Penn or go to the Western world. And I must appreciate my colleagues, especially people like Dr. Nasir, Dr. Firoz, Dr. Arshad Hassan, who refer me patients, who give me opportunities to come and teach at their centers, and so that this kind of training can be incorporated and can be given to other junior dentist or aspiring endodontist. We've also created a bespoke SIM. This SIM is for endodontic surgery that we've created, and we use this for our hands-on training. Before I end, I just want to give you a couple of helpful hints if you want to start off with microsurgical endodontics. Number one, most important thing is hemostasis. So if you see the picture on the left compared to the right, you would much rather be working on the picture on the right rather than on the left. So in order to get profound hemostasis in our cases, I used anesthesia with 150,000 epinephrine. Usually I give the patient this kind of anesthesia and ask the patient to wait half an hour or so.
Dr. Sahab, unfortunately, time is over.
I'm just gonna finish up in 2 seconds, right? So once we wait for half an hour, usually I find that we get a really good hemostasis, and you can work in that environment without, in a blood-less field, and you got good vision. I'm going to skip all that. Yeah, we've already talked about magnification and retrofilling material. I want to talk about a little bit. When I started off, I started using fancy retrofilling material like BC Pari. Eventually, I realized that we can use our different kinds of NTA which are easily available to us, like MTA flow is much more cheaper to use, and we have reasonable outcome with them. Even with IRM, I've received good outcome as long as we follow the principle of endodontic microsurgery and we can recreate a bacterial tight seal. Root end preparation tips are very hard to come by, especially in our part of the world, and that's one of the challenges that I faced. Right now, I would recommend that you can use tips from Woodpecker. They cost around 6,000 to 8,000 rupees, and these are really handy and cheaper as compared to the other tips which you sometimes have to import from the market. Usually I like to use 5-0 vicryl sutures. I usually find that the healing is very good. Post-op patients heal quite well with, not vicryl, but Prolene sutures. Micro instruments I've already talked about. Just a small video. So this is one of my initial surgeries that I did. This is going to take less than a minute. I don't use this burr anymore. I now use Lindenman burr, and we usually open the osteotomy with the Lindenman burr. Lindenman burr is 10 millimeter in length, so I can do my measurements with that burr, and as well as do the resection. I know what I'm doing. So right now, before I used to take 3 millimeters off from the middle, but I noticed when I used to do that, I ended up with doing a lot more resection than I wanted to, and now I just tend to shave off the root from the top these days. And these are certain learnings that I wanted to inculcate to the audience. Thank you for your time and your patience with me. All of this is not possible without a lot of input from my residents who help me with my documentation of cases. Thank you so much.
Thank you very much, sir, for your speech. To deliver today's next lecture on the updates on zirconia dental implants in prosthodontic rehabilitation, I would call upon stage Dr. Fahim Vora. He is professor in Prosthetic Dental Science Department, King Saud University, Riyadh, Saudi Arabia. Sir, please come up on stage and deliver your lecture.
जी सर कैसे हैं खैरियत से नीचे जाओ PowerPoint ये सारी ये मुझे एक मिनट सर, आप चेक करें। वहाँ आएगी, वहाँ से
I need a hand mic. Hand mic है, उसके हाथ में था। अस्सलाम वालेकुम। Assalamu alaikum and good afternoon. I know it's a Friday afternoon, so everybody's really tired. But we will try to make it as interesting as possible, inshallah. The topic basically we chose today is something of a futuristic thing. Hopefully people are thinking about doing these kind of implants. The idea came from basically we did a systematic review ourselves at King Saud University. And we found that there was a lot of evidence lacking with regards to zirconia implants. So we thought that why not we'll try and present it comprehensively. So the aim today basically is to present to you all the evidence available, biomechanical, biological, clinical, animal-based studies, just to present the data and then look at the summary and some of the indications and case-specific indications how we can present and use zirconia implants. So a little bit about myself. I actually graduated from Karachi Medical and Dental College. I don't know if there are any graduates or any faculty from there. I know Fahad is from Karachi Medical and Dental College. Then I moved for residency in the UK, University of Edinburgh, did my master's there, then Royal College of Surgeons of Edinburgh. We did our membership in prosthodontics. And then I joined King Saud University. So after joining King Saud University, I've been there for 12 years. It's a pretty good university. We have a lot of people who are trained from the States. And at the moment, we are using different kind of implants and having postgraduate and undergraduate training. I did my PhD during my teaching and then joined a couple of research departments at King Saud University. So without wasting any time, what we are going to be covering is looking at what are some limitations of the implants, especially titanium implants, and what's the evolution of ceramic implants, how they developed over time. And then we are going to look at the biomechanical and the biological aspects, clinical and animal-based studies related to zirconia implants. So we know titanium implants are the gold standard, and everybody is using them. There are thousands of companies, and they have a very good longevity because of their favorable biological properties, biomechanical properties, different types of implants, development of companies. So things are going pretty well, but still there are some of the limitations of titanium implants, especially the gray show through, especially in the thin biotype patients. So we still get these long, when you go 4 years, 5 years, 10 years, 12 years, you get soft tissue recession, soft tissue problems, and sometimes without grafting they can't be fixed. A lot of times they can be, but still there is a problem associated with the aesthetic of titanium and metal alloys. In addition to that, there is also some studies reported about sensitivity and to titanium implants. Moeller did an interesting study. They did implants in around 50 plus patients, and they found out that a positive patch test was among around nearly 40% of patients. And actually, when they removed the titanium implants, they found that the sensitivity was reversed. So they surely found out that there was sensitivity showing through patch tests through titanium implants. Cecilia looked at the epidemiological study. They just looked at allergies from titanium implants, which is also possible limitations. They look around less than 1% of allergies, which is already known. Then the presence of corrosion products. So it's been said that when they come in contact, the titanium alloys, they come in contact with saliva, acid recharge, fluoride, sometimes bacterial biofilms, they tend to produce corrosion products, surface oxidation. What exactly these corrosion products cause to titanium implants are not exactly known, but they can facilitate or accelerate the already existing soft tissue inflammation around the implants. So the question is, people as looking for something which is metal free, and initially we looked at the evolution. So we had titanium implants and then titanium abutments. Now we have moved from titanium implants using zirconia abutments. And the future is looking towards zirconia implants as more and more companies are pushing towards metal-free implants. So the evolution of, we basically in the 1970s, we found that aluminum implants were also available. It was commonly known as the single crystal sapphire implant. Osseointegration-wise, soft tissue adaptation-wise, they were very good implants. But biomechanically, they showed a lot of failures. And as you can see in the study at the bottom, they showed around 65 to 92% of success, which is not acceptable clinically. So we started moving away from aluminum implants, and the natural transition is towards zirconia implants. And zirconia, we know we already been using zirconia for multiple opportunities and multiple applications. We know the biological properties, biocompatibilities, bacterial resistance, bacterial adhesion, soft tissue inflammatory capability. All these are much, much better than titanium implants. Mechanical properties, if you look at fracture resistance, corrosion resistance, non-mutagenic, non-carcinogenic. Also the important property is phase transformation. So we know when zirconia changes from tetragonal to monoclinic, it provides you crack stoppers. So even if you have surface irregularities, it is expected to provide good mechanical resistance. And we already know, even nowadays we are using zirconia for post-in course and pretty successful. Although the failures are catastrophic, but their longevity is more than 10 years. So we already know that zirconias are being successfully used. And orthopedics, zirconia, hip joints, femoral heads are being used from a long time. And some of the studies have already shown that they are comparable to the cobalt chrome alloys in terms of replacement of hip joints. So can we replace titanium implants? That's the bigger question. Are they surrogates? Can they replace zirconia implants? We have to look at the evidence. So biologically, we look at the implant designs. You need to look at the fracture and the stress analysis, low temperature degradations. Then soft tissue reaction, how is the osseointegration, how is the fibroblast attachments, bacterial adhesion, and animal studies, and then gradually moving towards clinical studies, that what is the clinical evidence through randomized control trials we have available. So a lot of people think, do zirconia implants exist, and what are the systems providing zirconia implants? And I can tell you there are a lot of systems. All these are commercially available systems. Most of them are present in Europe. So it's mostly being promoted through Germany and Switzerland. But ITI Straumann has also started producing pure ceramic zirconia implants. They are producing one body, single body, and they are also producing two-piece zirconia implants. So these are the main two types in which we have zirconia implants. We have the one-piece ones, which has the abutment attached to it, and then we have the two-piece ones, and then we have the ones for complete dentures, which are used as implant over dentures. The main companies, Zircolit, Z Systems, and Serraroot implants, they are different in terms of their alloys, in terms of the exact composition. But the majority of zirconia implants nowadays used are one-piece implants. Of course, we know one-piece implants, as we do implants, we know one-piece implants have their limitations, especially when you talk about prosthetic convenience. So their placements are very technique sensitive because you can't adapt the abutment according to the availability of prosthodontic space. And then the availability of angled abutments in zirconia implants is also limited because of the biomechanical limitation. And then if you end up preparing zirconia abutments on, say, one-piece implants, that's also a complication because it's not recommended. It can result in biomechanical failures. One-piece implants, again, we can't temporize them. If we temporize them, it will be immediately temporized. So osseointegration may be compromised. You need to have very good primary stability. And then if you have a previous abutment and the soft tissue adapts to it, we know soft tissue adapts slowly and reaches its permanent position over a period of time. So then we have to prepare them. The margin has to be prepared. And then one piece also doesn't allow you to do screw retained. So it has to be always a cement retained implant restoration. Then we have the two-piece zirconia implants like we mostly do in 90% of our cases. We have two-piece titanium implants. But the connections at the moment are being used as either titanium alloy screws or carbon fiber screws. Or most of the cases, or most of the studies we will go through, we'll see that the abutments are being cemented to the implant through resin cements. Another connection which Straumann has introduced is for the components. For example, you have to take an impression, you have to take a guide, you have to take a bite. They have introduced rotational lock connections with the inner thread, and they are promoting those along with the carbon fiber screws as a long-term definitive restoration. The problems which we are having with two-piece zirconia implants, again, if you use the titanium screws, they end up producing biomechanical discrepancies on the surface of the abutments. And if you use the carbon fiber screws, we don't have long-term evidence to show that they are biomechanically resistant to fracture. And if you use the cemented abutments, then you don't have any way to go back and fix the problem if the abutment anytime fails. So you've got to remove the whole implant and the abutment assembly. So most of the challenges which we have in zirconia implants are not biological but mostly biomechanical, especially at the implant abutment interface. So this is an in vitro study by Kohal which they looked at the fractures, and they found out that when you end up preparing the zirconia implants, which is one piece, the fractures are usually through and through the abutment. But when you don't prepare them and the fracture, the masticatory loads are really high, you end up having fractures which are at the threads which are horizontal fractures. Then there's some more data available about two-piece implants and their fractures, and they showed that the fracture in two-piece implants were much more salvable. So you can salvage the implant, you can save the implant and sacrifice the abutment because you have a connection. However, the fractures were still very low, but this data is just 12 months or 24 months follow-up. This is not a long-term data. Then Kohal in 2009 actually compared, I think, zirconia and titanium implant connections. So this was an interesting study. This is the first study they started comparing the two to see the fractures. And they found that in titanium implants, the fracture was at the screw, but the zirconia was fracturing at the abutment or the head of the implant. Although the loads were really high for zirconia implants. So it fails later, but when it fails catastrophically. This is another study which they looked at an in vitro connection and the gap at the IAC and surface. They compared the surface roughness of the zirconia implants. And they also looked at the performance of carbon fiber screws. What they found out was that the carbon fiber screw was performing really well. Again, it's an in vitro study, it's not a clinical study. But the fracture was under the carbon fiber screws. So the black part over there, you see, it's a connection. At higher loads, the screw did not fracture, but the fracture was at the conical part at the base of the fiber screw. which indicated basically that the material itself had to be reinforced. Again, there was another study which looked through the FEA about the stress analysis around zirconia and titanium implants. And they found basically that the zirconia implants performed well if you put them in a model of an FEA, finite element analysis. The surface area was good, the stresses were favorable, and they were not destructive. So in terms of in vitro experiments, they were good. We already know that there is low temperature degradation among zirconia implants, and this was actually later on identified, and then they stopped using them for femoral head replacements. So they found out that the surface of femoral heads, when they come in contact with the body fluids over a period of time, they undergo low temperature degradation, which we know zirconia has a limitation. But as a result, there were more fractures of the femur heads. So it is an indication for us also that we might have to come across this problem. Soft tissue integration, all the studies which evaluated the soft tissue attachment, fibroblastic attachment, junctional epithelium, biological width around zirconia implants, they've always shown significantly better outcomes as compared to titanium implants. So especially the study at the bottom, Linares in 2016, they looked at some of the zirconia implants within the titanium and zirconia within some guinea pigs. And when they took out the whole sample and looked at under the microscope, did histomorphometric study, they found out that the junctional epithelium around zirconia implants is lesser in size and as compared to the titanium implants. However, the biologic width was actually greater in dimension, which is a good thing because junctional epithelium is this tissue where actually the inflammation starts. And if it's more sensitive and less supported by the connective tissue, there's more chances of peri-implant mucositis or peri-implantitis. I'll just go through these three factors here. So we already know osseointegration is how key, but the factors which affect zirconia implants and link them to osseointegration are the design and the surface and their biocompatibility. So biocompatibility wise, we are pretty good. Also, it's very important to understand that when we are doing implants, we are looking for, if you need more primary stability, you're looking for more contact osteogenesis. So the formation of bone on the surface of the implant rather than the bone forming from the outside, from the old bone towards the implant. So for the formation of bone on the surface of implant, that contact osteogenesis, we need a good receptive zirconia implant surface. So the implant surfaces have been evaluated in terms of the attachment of osteoblast, attachment of platelet cells to see how they are osteoconductive or not. And studies have shown that rougher surfaces, zirconia surfaces are much better as compared to smoother surfaces, as we know for titanium implants. This was an interesting study by Yamashita. They looked into osteoblastic cells growth on rougher and smoother implant surfaces. And what they found out was that rougher surfaces, if you have an RA of around 1 micron or more than that, you get a better bone formation, more osteoblastic attachment as compared to smoother surfaces. Again, when we look at bone formation,
2 minutes.
Thank you, sir. Again, when we look at bone formation, we have to think about the scaffold formation, the scaffold which is formed around, osteoblast. And that scaffold is key because all the blastic cells, when they convert to osteocytes, it's very critical for them to form new bone. And the rougher surfaces, especially the plasma spade or electrolytic coated surfaces, they provide very good primary stability and good bone formation in terms of smooth, as compared to smoother surfaces. I'll skip a few slides here just to, this is one of the animal studies in which, when you try new implants or new systems, you do some animal studies. And most of the time, they look at the BIC, which is bone to implant contact. They look at the removal torque values. And these studies basically showed that the removal torque values and the bone to implant contact was comparable in an animal study between the titanium implants and the zirconia implants. So positive results, encouraging outcomes for zirconia implants. This is a slide just showing the maturation of bone around zirconia implants. And you can see, if I use the pointer, on the slide on the right, you can see the mature bone formation. So the osteoblastic cells, when they mature and the new bone is converted into mature bone, they become osteocytes. And you can see that the osteocytes are being attached to the implant surfaces which are being treated. Bacterial adhesion is a very key factor. So mucositis, peri-implantitis, it starts with plaque. What is plaque? Plaque is a film of bacteria. So if we have a material which is resistant to bacteria, that would be ideal for implants as well as its aesthetic. Different bacteria show different adhesion towards titanium implants or zirconia implants, especially the ones which are accompanied in peri-implantitis, Porphyromonas gingivalis. They all show the same affinity to zirconia as compared to titanium. Although the development in some of the studies has shown that the maturity of biofilm is always less in zirconium as compared to titanium. One reason for that would be the low surface energy and the low surface wettability of zirconia implants. So this is another study. They showed that zirconia implants always showed thinner biofilms which are less mature, less rods, bacteria. Again, inflammatory potential is something that, you always have a healthy inflammation in your physiology in the body. The periodontal sulcuses always have some inflammation. But in terms of biocompatibility, zirconia is a very good material. So studies have seen, animal studies have shown what is the inflammatory potential for zirconia implants. And this is assessed usually by either taking an in situ soft tissue and hard tissue graft from the animal studies. And they have shown that the inflammatory infiltrate is always low in zirconia implants as compared to titanium implants. Also, we sometimes look at the peri-implant or periodontal circular fluid, the rate of peri-implant clavicular fluid and the cytokines, the pro-inflammatory cytokines in them. And they are comparable, what studies have shown.
Sorry, the time is very limited.
Just a couple of minutes and then I'll be done. Thank you, sir. Thank you very much. So pro-inflammatory cytokines basically I was talking about. So their levels are usually low when we compare the zirconia implants as compared to, which indicates that the inflammatory aspect of zirconia implants are kind of lower as compared to titanium implants. I put in this slide actually because, doing my course at King Saud University, we'll be doing a lot of research. And one of the systematic reviews after this I'll be showing you was actually conducted at our department. So one of the profiles, as a lot of academics are sitting here, and especially the trainees who are training in prosthodontics, I would suggest them to make some profiles on, especially on ResearchGate. ResearchGate is a good tool where you can download free articles, full text articles, because a lot of universities in Pakistan, you can't get the resource. So your supervisors or your examiners, they ask you about evidence. But when you go to download these evidence, sometimes it's really tough to get that evidence. But ResearchGate, and there are certain other websites also, when you go out there and you look for evidence, you can find full text articles. If you even don't find, you can find authors through which you can message them and say, can you send us a private full text article? And a lot of them would help you. So during my course there, alhamdulillah, we were able to publish a lot of work. And, we have collaborated in the last 4 to 5 years even with institutes in Pakistan and try to help them out in any way possible in publishing a lot of research. So this is something a little bit away from the topic. Going back to our topic, so looking at the clinical evidence. Now we want to look at the evidence. So this was one of the systematic reviews we did in 2015. Actually, this is from where we got the idea of doing this presentation. So we looked at the studies which have been published, and we looked at the peri-implant bone loss, pro-inflammatory cytokines around these implants. And we found basically there were not much studies, although there were systems who are already marketing zirconia implants. Only 13 studies were found, and the outcomes were also not very good. A lot of studies did not show a comparison to titanium implants. So if you're not comparing it to titanium controls, you're not getting into any conclusion. And we found that success rates were really, survival rates were really variable, 60% to 100%, not very reliable. So we concluded that we need to do further studies to show the outcome. One of the systematic reviews which was really groundbreaking was Hashim's systematic review, which presented a lot of data, but again, their conclusions were also pretty good, but they were just based for 1 year. So survival rates they presented of 2-piece zirconia implants or 1-piece zirconia above 90%, which is encouraging. But again, these outcomes were based on 1 year implants. So looking at some of the tables from their study, So this is one of the cases which actually in the Hashim's paper they presented a follow-up of 4 years, and they showed that good bone loss, they showed good bone formation and soft tissue outcome based on their experience. What they looked at in the studies, they found out that most of the studies which they reviewed were short-term studies. So this was only study 2 to 5 years, but a lot of them were short-term follow-ups. So the purpose of presenting this data here is to see that how evidence can be read and how you can look through the evidence to find out what are the real answers. So if you look at here, these are the studies looking at how zirconia implants could actually replace titanium implants. But none of these studies are actually comparing zirconia implants with titanium implants. They're just reporting the outcomes of zirconia implants. And in the right side, if you see the success rate, none of the studies reported the mean bone loss or the success rate except one study by Olivia. The success rate was quite high, but again, the follow-up was just 40 months. Moving on to the next slide. These 3 studies were really good studies, very well documented journal of prosthetic dentistry. But the problem again
is the time is really very less.
Okay, sir.
Please conclude.
1 minute. I'll just finish in 1 minute. So these were short-term follow-up studies, 12 months, 48 months. And just quickly go through, I'll show you that the survival rates are really high here. But if you look at the follow-up is really low. So 12-month follow-up, if you get a 90% survival rate, you need long-term follow-up studies. Again, these studies are not comparing zirconia implants with titanium implants. That's the main problem. One of the studies here at the top, the study by Royling et al. This was a groundbreaking study as well because they'd follow up the implants for 6 years. And they showed the success rates were not very acceptable. So 77%, 58%, around 89%, which shows that the evidence again for these implants is really weak. I'm sorry, I have to just skip a lot of stuff. If you look at the columns on the right, the extreme right, you will see that the early and late failure fractures. So if you see, the most of the studies showed that the failures in these implants are early. Late fractures are very low. That's interesting. And the other thing is the failure were not just fractures, but they were also biological failures. So just to, in summary, what we looked at a lot of in vitro and in vivo studies. And biologically, we see that, the inflammatory potential is low, low corrosion potential, low chances of peri-implantitis, the more risk of biomechanical failures. The more commonly used implants are one-piece zirconia implants. If there are two-piece zirconia systems, they are being cemented with resin cement. The abutments are being cemented with resin cement. I would say 70% of the published data is two-piece zirconia implants, or all of them are cemented. The problem, the failure loads which are shown at the moment are within, you can say 20 to 30%. All of them are mostly biomechanical. But the problem is the follow-up of these failure rates are not more than 3 to 4 years. There are just a couple of studies which show 6-year follow-up rate. Otherwise, most of them show 24 months, 12 months, and that's all. So what I would say is these implants are still recommended, but the case selection is key for these implants. So in cases which are really low, high aesthetic demand and low biomechanical demand, good bone formation, no need for any grafting, no systemic problems, good bone type and width, so we know type 1 of the, how much bone we have and what's the density of this bone. Occlusal loads are low. Thick biotype, so thick biotype patients are much more better for thin biotype patients. So case selection for zirconia implants, I would suggest, is key at the moment, and looking at the biomechanical aspect of it. More evidence is due to come down the line, but what I would say is we should start doing some of the, as the implant dentistry has evolved and developed, we should start pushing the boundaries and discuss with other people who are actually doing zirconia implants, discuss with them, you know, on lunch or on a cup of tea, and just try to see how we can start doing zirconia implants. Because it's a demand and supply. If we start demanding these implants, hopefully we will start doing these implants, especially in the anterior zone. So thank you very much for your time. Thank you very much, sir. Apologies for the delay.
जी 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 मैं डिलीट करता हूँ। कौन सी वाली? ये वाली सबसे नीचे।
जी डॉक्टर आदिल।
Thank you very much, sir, for your essential lecture.
To deliver today's next lecture on basal implantology, I would like to invite Dr. Adil Abushak, President of International Academy of Cortical Implantology, Rome, Journal Manager of Swiss Dental Center, Palestine.
Can you give me the microphone, please? Thank you. Do you have the change? What is there? Remote?
All the speakers are requested to kindly finish their presentation within 20 minutes.
I will not take 20, less than 20 minutes, inshallah. Assalamu alaikum again. Bismillah walhamdulillah wassalatu wassalam ala rasulillah sallallahu alaihi wasallam. In my first lecture, I spoke about the concepts of basal implantology and immediate loading. Now I'd like to speak in this lecture about the techniques, because my colleague Dr. Fahim spoke about zirconia implants, and because I think crystal implantology, two-stage implantology is going to disappear next few years. This is my opinion, of course. Because even as you see, there are no enough research on zirconia implants, because even it's contraindication for us to put zirconia bridges on basal implants because of elasticity, and it's usually break. So we put only metal to porcelain or metal fused to plastic. It's okay. So I'd like to speak about the technique of lingual engagement and buccal bypass and pterygoid implants. If we have severe resorption in the distal mandible, we place our implants according to the place of the ID canal. You know, this is the challenge on the mandible for dental implantology in general. So we have two techniques. We do lingual engagement or we do buccal bypass. Lingual engagement means engaging the implant in the lingual plate. So we are going towards, we drill and place the implants toward the lingual plate. So the myeloid ridge, second cortical. As you see, we have about maybe 4 maximum to 5 millimeters bone, but when we go lingually, we place implant maybe 14 millimeters. So this is, this implant is lingually engaged, as you see. Even it should perforate the second cortical, as you see in the CBCT. Usually this part, which is outside the bone, After a few months, it will be covered with bone. We have research and we have follow-up cases which showing this. As you see in this this slice at 12 millimeter from the cemento-Iman junction, you see this, the part where we engage our implants, we usually have from 2 to 3 millimeter thickness of basal bone, D1 bone. So this is the lingual engagement technique. You see, this case was referred to me from one colleague. There was pain, and these implants, as you see in the end, on both sides, they are not lingually placed, so they just were placed like two-stage implants. So after 1 year, because of masticatory forces, they start moving. Then we just cut the last 2 implants from the bridge, but I think again the patient will have pain from the other implants. So any basal implants, if they are in the distal mandible, if they are not lingually or buccally engaged in the second cortical, they will get primary stability, but in few months, in 1 maximum to 2 years, they will move. So the technique, we drill lingually distally, as you see. This is the direction of drilling, and also the direction of inserting the implant. Then after putting the implant, we just bend the implant for parallelism. These distal implants, as you see, on both sides, they are lingually engaged. You can see how they are. We are so far away from the canal, but we can also insert longer implants, but enough to insert 14 millimeter implant length. This is the follow-up. This is the follow-up after 2.5 years. As you see, the apex of the implants nearly is fully covered with bone. This is the same case which I showed before. Because it was perforated, it's pushing the mucosa. In few months, it will be covered with blood. It will be covered with blood, then it will be covered with bone. Even we can do lingual engagement with compressive implants. As you see, these distal implants, they are lingually engaged compressive implants. You can see in the CBCT the canal, and they are so far away from the canal. This is the CBCT for both sides, how they look in the bone. But it's very important that compressive implants, because they are rough surface implant, they should not perforate. They should not perforate. They should only reach the second cortical. You will feel that they are in the second cortical, but they should not perforate. In the opposite, basal implants, because of smoothness of the implant, it can perforate. Bypassing the inferior dental nerve, here the technique is completely the opposite. We come from inside to outside. And usually, these are the only implants which I do not place with the hand grip, which I'm using it, because you cannot go inside the patient mouth, so you have to use the ratchet and the placement aid. The same thing here. As you see, you should perforate and feel the implant. Then it should also engage the buccal bone, the buccal cortical. This is the technique, and of course, you see even the bone the buccal bone is more thick than the lingual one. So bypassing, it's just not going straight to the canal. You just go behind the canal, you drill, and you place the implant. See this buccal bypass, the canal is too close, so we do the buccal bypass technique. We just drill. Another case, as you see, one of them is lingually engaged, the other one that it's buccally engaged. As you see, we just drill slowly with, of course, with CBCT, and we place the implant. See, we can simply just solve the problems of no need for bone augmentation. As in basal implantology, we cannot augment. I have never known any of my colleagues who is using basal implants is doing any bone augmentation or nerve repositioning. We only use the patient's bone, which exists always. As you see here, it's only basal bone. So it's more easy to put shorter implants sometimes. As you see, we just come from behind the canal and engage the implant, sometimes lingually, sometimes buccally. And if you see in the CBCT, the implant also is far away from the canal. I shortly will speak also about pterygoid implants. Pterygoid implants are those implants which are placed in the distal maxilla. Any implant which is placed in the place of 7 or 8, it's called pterygoid implant. Placing these implants depends on the type and the quality of bone in the distal maxilla. Usually when we have osteoporotic patients or very spongy bone, we don't place basal implants, we go to compressive. We place compressive to compress the bone. Implants must be engaged in the second cortical, which is one of the following cortical: wall of the anterior or sinuses, distal wall of the maxilla, sphenoid bone, all three mentioned areas. Why all three mentioned areas? Sometimes from the place of 6, we drill, we perforate the sinus, we perforate the distal wall of the sinus. Again, we perforate the distal wall of the maxilla to reach or to hit the lateral pterygoid of the sphenoid bone. Length of implants is determined by the distance between the implants, crystal entrance into the bone, and the oppositing cortical, which is intended to be penetrated. Therefore, the average implant length in the distal maxilla is between 17 to 29 millimeter. Engaging the mesial wall of the sinus. As a second cortical, you see the first, in classification, the first type of engaging the implant in the mesial wall of the sinus, engaging the distal wall of the sinus, engaging the distal wall of the distal maxillary bone. So as I see that implant is in the distal wall of the maxilla, the other one, it's outside. Of course, it's engaging the sphenoid bone. Sometimes even double pterygoid we can use, the junction area of the wings of the sphenoid bone. Inserting the implant into the direction of the lateral wall of the nose to anchor the implant in this nasal part of the maxillary bone. So these are pterygoid implants. We are daily doing them, and it's very easy to bend. If you use titanium grade 4, easy to bend, but in grade 5 titanium, it's sometimes, the bone in the distal maxilla always very spongy, so it will be a bit difficult to bend when you are using implants grade 5 titanium. So in this case also double pterygoid implants. As you see here in the CBCT, it's clear that usually the front implants, we engage them more palatal, and here you can see these implants are engaging the sphenoid bone. This case was done in 2015. Of course, 3 of these implants, as you see, one of them zygomatic, they are perforating the sinus, because to place zygomatic implants, we should do it transsinusal or subperiosteal. We have 2 techniques in basal implantology to place these implants. And also the lower disc implants, as you see, is fully osseointegrated. This follow-up was two years ago, and still we have no infection, nothing. Even we are going transsinusal. And thank you for your attention. I'm going to use many of this data in my book, so can you delete it, please? Please, okay? Thank you. Thank you very much.
Thank you so much, sir.
To deliver today's next lecture on multiple options for restoring edentulous jaws with dental implants, I would like to call upon stage Dr. Kashif Ikram. He is Principal, Buckeye Dental College, Buckeye Medical University, Oral and Maxillofacial Surgeon in Oral Medicine and Implantology.
हेलो अस्सलाम वालेकुम। वो लास्ट छाछ बचा है नीचे का, सो लेट अस सी, कोशिश करते हैं कि क्योंकि लेट्स हैव अ लुक देयर। अच्छा, while they're doing it, my is ready now. I was having lots of patients for restoring the jaws without any teeth, and then I figured out कि हमारे मुल्क में patient can't afford too many implants and implant dentistry. So I searched and looked for the different avenues. So I found less number of implants, which is 4 implants. So I collected about 15 years of data of my practice, and I'm going to share with you how different ways I attempted to do and restore them surgically as well as prosthetically. But I'm not a prosthodontist. So to do prosthetics, I went all across the globe and did some courses and workshops because they say it should be a prosthetically driven surgery. This is a topic of my talk, if you're interested. Human emotions and behavior influences the performance of the practice. Very interesting what your think is. So let's go quickly to the main crux of the presentation. I always believe we treat the patient, not the tooth, because we try to fill the khaddas and remove the tooth, but we don't see the patient as a whole. So all the youngsters treat the whole patient who needs dental attention. हमारे माशरे में दांतों का इस्तेमाल खाने में बहुत होता है, so you make sure कि teeth are available for chewing. All across the world, लोग अगर खा नहीं सकते तो healthy नहीं रहेंगे. To keep it interesting, I will move forward for the main cases because bone preservation is very important. This was the case. I find almost all the patients who have acidic pH. Because when you take lots of fizzy drinks, you lose lots of bone. And when you lose lots of bone, periodontal compromise situation, you lose teeth. अच्छा, हम जब implant लगाते हैं तो we do not sell implant. Our job is to preserve the bone. And bone resorption is very fast in the first year of the tooth extraction. So is this adequate bone? You think so? Or is this adequate bone? We need to prevent this to happen. I'm not a prosthodontist, but जब patients से कहते हैं कि why your dentures not fitting properly, we have one reason. And it says, ये lab का fault था. And we put everything on the lab. But actually, the bone is been resorbing, and we do not tell the patient it's our job to preserve your bone by saving your teeth first. If not, then giving implantation. This much force we use to chew. And with the denture, it's all gone down to 5.6 psi. So what do you expect the patient to chew with the dentures? So at this day and age, the lower denture should not be given without implant retained prosthesis. The occlusal forces are tremendous. 30, 40, 50 kilograms से हम खाना चबा रहे हैं. And if you cannot chew properly, imagine what will happen to the human health. This was the pictures I got by many referral dentists. People are putting implant left, right, and there without any planning. So I met all of four concept by Paulo Molo. They says you can restore the whole arch by just 4 implant, provided you follow all the guidelines. Many companies are producing all those components for this. There are many studies for the survival of removable and fixed prosthesis by just 4 implants. So this is my brief data of 55 jaws, 250 implants, and 15 years of the era. So I rehabbed this with mostly 4 implants, few of them with 6 implants. I had 2 surgical failure and 2 prosthetic failure out of these 250 implants. And the reason being the patient went diabetic and went away, and when I met the patient again, it was 7 years. And the prosthetic, patient chew nuts every day with a glass of wine every night. So he never came back to me. These are my pre-op assessment. I do CBCT for all my patients. After this, I do not do any implant, चाहे वो एक ही implant हो, without my CBCT. I use both types of implants in those 250 implants at tissue level or bone level. People happily using tissue level I found in Punjab. For some reason, somewhere compare into Sindh. But you can ask me a question in the end, why is that? The type of prosthesis we chose was overdentures, hybrid screw retain, porcelain bonded to metal, PFM, metal barb is zirconia. ये 4 तरीकों से उनको restore किया गया. And these 4 companies implant I've used. So all patients are consented for pictures to share for educational purpose, and all pictures were taken on with smartphone. I'm not trained to take pictures, so just to give you encouragement, you can record, and you must record all your patients with the smartphone for talk like this. So let's start with the first case. Overdentures. हमारे पाकिस्तान में bar overdentures बहुत कम लोग बनाते हैं. There's one guy I found in Karachi, started making it. But I prefer always 4 implant overdentures, not 2 implants. So for overdentures, you make dentures first. It's done by my prosthodontist. ये मैंने नहीं बनाया. But you got to work in a team. The concept is an implant surgeon is a combination of 3 people: a perio, a prostho-restorative, or a surgeon's. Either you won all combo, all 3 in 1, or you use all 3 your colleagues and helps. You cannot just think that you screw the bone and you have a successful implant outcome. So I will skip this because it's simply overdenture. But if I have a chance to do this case today, what I would do is, I would do it a different way. So I'll leave this to you. You can ask me a question, how different in the end. Second case, most of my, my patients who come to my practice, they belong to the well-off category. But 20% are the one who cannot afford implants. She is the one who didn't spend a single penny. I've showed a couple of more cases as well. So I make sure that there's some way to treat the people without spending a single penny. So इस बिटिया की शादी नहीं हो रही थी और she didn't have teeth on the bottom. So we restored the upper with acrylic first, and I removed the teeth first. Let it heal in a 2-stage surgery. So I placed 4 implants. The idea was to restore it with the fixed prosthesis eventually, but initially give a overdenture. Then I gave a graft to have a keratinized tissue around the implant because one of the implant on the bottom right needs some gingival cuff. We know that if there is no keratinized mucosa, our implant, it will fail. So these are the few things which I will not spend time because I know you are more qualified than me. So this is an overdenture case, simple and the top is acrylic, the bottom is PFM, and that's the overdenture case. After 5 years, she came to me. This picture, I just took it, I think, last week. And I cleaned the denture. Case number 3, hybrid. Hybrid is you make acrylic denture with a bar and you screw them on the jaw. These are components. You can go back home and see in Kadam kya hai. They are the multi-unit abutments. Through them, you fix the prosthesis to the jawbone. A CBCT of a patient who needs the fixed prosthesis on the bottom, then I removed the teeth, did the abuloplasty, did my measurement, and placed 4 implants at the bottom. And then put my octa abutment or screw-retained abutments through which I will restore them. I always take open tray technique because I think open tray give you a better result than a closed tray, which I learned from the courses, yes. And I thoroughly enjoyed prosthetics by doing this. This is Duralay. When you take impression, you tend to move the impression. So you always use Duralay and cut Duralay and re-impression if you think there's some discrepancy on the patient's bite. And this gentleman we restored only last week. He only needed fixed prosthesis. Now what we'll do with this? Ideally, this is a patient of a bone graft, block bone graft. But she said, "Mujhe bas daant samne laga dijiye." So we removed them, did a measurement, and placed 4 implants. She needed a 5-to-5 restoration, short dental arch with PFM. Now, there are 2 sim pictures. It's just when you take picture from a flash or without flash, you need to see ki shade kya aa raha hai. So just to tell you the difference of light difference, so you make sure कि आप light के बगैर picture लें, ताकि lab में अच्छा बैठ सकें. This is not all 4. This gentleman need fixed prosthesis, so I chose to give 6 implants and split into 3 units. But I did my planning on CBCT with surgical guide, and so restore in the interior and the 2 posterior segments. In my practice, 95% time I do open tray impression because when you practice regularly, it's becoming second nature. And we always try all the steps, the BIS trial, the metal trial, and maybe 2 trial if the patient does not like the height or the weight of the prosthesis. So that's he's in the end. Now this patient has no bone, and the problem is she can't afford it as well. और इसकी भी शादी नहीं हुई थी इस situation में. So we place implant in the available situation after measuring the available bone, but we give a hybrid prosthesis. और जैसे ही इसका hybrid लगाया, and she came to me, she got married. Then she came to me for the top. Or top mein there's no bone, and she said I want to conceive, so I cannot afford long surgeries. So what I did, I placed this 1.5 screw and puts the bone, Shoro's bone. I went through some studies. I found it actually holds with these screws, and then I closed it and did a CBCT. Then this 0.5 millimeter bone I grew, and then eventually this much bone we got rebuilt by this GBR by pins, 1.5 millimeter, and the bone. Then we did FGG, keratinized on the lower label mucosa. Then she came in with a dirty denture. I cleaned it. That's the place implant on the top, and this is the build we actually got after the GBR. And I'm still working on this. I still not yet restore her, but this is a trial. I got it from yesterday, and she was very happy. And this case is interesting. A simple case, you can place 4 implant, but always measure buccolingual measurement. You should always have 2 millimeter bone, 3 millimeter gingiva, otherwise your implant will fail in due course of time. This gentleman has a prosthetic failure because he used to chew the nuts. And then I gave a PFM with the promise that you will not chew nuts. So I'm showing you all the steps because if you do not follow all the steps, you do not take pictures of the step, you will miss how you learn yourself. How much time? Yes. So this is the duralay we broke, and then we re-impression again. ताकि precision अच्छी हो, बार बैठ सके उसके ऊपर. So I want to show you this is a case step by step how to make hybrid. This patient was puppy of my mate's son. Again, she didn't spend a single penny. And she had nice surgery. We planned to give a top all 4 concepts, and we gave 4 implants. We went through the literature. They work very well, provided you split them together. Because if you place implant in the oblique fashion, they're going to fail. So you got to split all 4 together to prevent the failure. That's the all 4 concept by Paulo Moro in angle implants. So when we restore them, it came with duralay. The discrepancy in impression. We broke it, we re-impressioned them with the impression copings, and then send the lab and make the bar. With the bar, if you see closely, there's a discrepancy here between the abutment. This can only be seen with the picture magnification. Your eye will not check it. So you take a picture of the model, magnify it, and then tell the lab that it is not fixing properly. So pictures always help you. And then you proceed with the normal process of denture. Now this prosthesis is done by my friend. He took the Facebook readings to see the label fullness. And then comes the wax trial. Is height taller of the incisors, in the try in the mouth, and that she is before and after, because she loved it tremendously. She got nice teeth. And this is the last case for zirconia. This implant was done somewhere else, and I've discovered how to make the zirconia bar. Every tooth is luted separately on the metal zirconia bar, and by doing this, you can actually give a nice aesthetics to the patient. And she loved it. With these, I like to end my talk here, except for the last case, if you're interested in width split and the GBR technique, and we actually grew this and grew the bone. So I just stop all the cases and I would go my end slides. I call my patients every 3 months for review and hygiene. And I always tell all the trainee to be ready for all the complications. Just a few take-home messages that you need to work on competencies, prepare for higher degrees qualification. I went across the world and learned the prosthetics because being a surgeon, I was not trained to, but my patient need a good prosthesis. और ये मैं अपने लिए बोलता हूँ कि उम्र भर मैं यूं ही गलती करता रहा गालिब, धूल तो चेहरे पे थी और मैं आईना साफ करता रहा। और ये मैं अपने लिए बोलता हूँ कि मेरी हिम्मतें अभी झुकी नहीं, मेरे हौसले अभी बुलंद हैं, मुझे हार जीत का गर्ज नहीं, मेरी जंग थी से मैं लड़ गया। और ये मैं आपको बोलता हूँ कि अगर तुमसे कोई पूछे कि ज़िंदगी क्या है, हथेली पे ज़रा सी खाक रखना और उड़ा देना। आपका बहुत शुक्रिया, थैंक यू वेरी मच, पाकिस्तान जिंदाबाद।
Thank you very much, sir, for your beneficial lecture.
Now, I would request the respected panelists to please come forward and present the souvenirs to the speakers of second scientific session.
I would like to invite Dr. Fahad Umar to please come up on stage and receive your shield of appreciation.
I would like to request Professor Riaz Ahmed Baraij to kindly come on stage and receive your souvenir.
Now, I would like to invite Dr. Fahim Vora to please come up on stage and receive your shield of appreciation.
I would like to request Professor Adil Abushar to kindly come on stage and receive your shield of appreciation.
I would like to invite Dr. Kashif Ikram. Sir, Sir, please come up on stage and receive your souvenir.
This brings us to the end of this session. Thank you everyone for taking your time out and staying here with us. Thank you so much.
We're looking forward to see you all at Musical Night tonight at sharp 8 p.m. Till then, have a nice day. Take care. Allah Hafiz.